Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Thank you all for joining us for today's podcast titled Stridor and Struggles, Sleep in Multiple System Atrophy, or MSA. MSA is a neurodegenerative disorder that is less common than Parkinson's disease, but yet important to sleep specialists, as most patients with this condition may have significant and disturbing sleep disorders. To discuss sleep in MSA, my guest today is Dr. Michael Silber, professor of neurology and a board-certified neurologist and sleep specialist. Mike, thank you for joining us today. Please start by telling our listeners who are not neurologists a little bit about multiple system atrophy.
Well, thank you, Maitri. Multiple system atrophy is less known to sleep specialists than the much more common Lewy body Parkinson disease, but it's a really important disorder for sleep specialists to be aware of because of that strong relationship to sleep disorders. So it is a neurodegenerative disorder like the Lewy body disease, characterized by accumulation of abnormal protein alpha-synuclein, abnormal forms of alpha-synuclein. But whereas in Parkinson's and dementia with Lewy bodies, the alpha-synuclein it forms into inclusion bodies in the cytoplasm of neurons called Lewy bodies, in multiple system atrophy, for reasons we don't fully understand, the alpha-synuclein, the abnormal form, accumulates in different inclusion bodies, mainly in oligodendrocytes, one of the supporting glial cells of the nervous system. The patients present slowly, like any neurodegenerative disorder, and almost all of them have quite significant autonomic disease. So they often will start with orthostatic hypotension symptoms, drops in blood pressure on standing up with related symptoms, sometimes with bladder dysfunction and other autonomic complaints. Then they will all, in order to get a diagnosis of MSA, must have a movement disorder. So they must either have cerebellar dysfunction, ataxia, in which case it's called MSA type C for cerebellum, or Parkinsonism, in which case it's called MSA type P. Now, obviously, if they develop Parkinsonism, the first thought of neurologists, they've got idiopathic Lewy body Parkinson's disease. Can you separate the two out early? Well, it can be rather difficult, but the Parkinsonism of MSA is almost always symmetric, whereas Lewy body Parkinson's disease, very often one side's more affected than the other. The tremor part of Parkinson's is commoner in Parkinson's disease than in MSA. And then if you treat them with levodopa, patients with Lewy body Parkinson's disease almost always have a nice response, at least initially, whereas MSA patients either won't have a response at all or a slight response which fades rapidly with time. There are some both Parkinson's disease and MSA can have autonomic disturbances, but they're more prominent in MSA, so that may be helpful. So if you have the MSA type P, it may be hard to make a diagnosis early on. MSA type C is a little easier. The time course of the disease is about 8 to 10 years. It's degenerative. There are no definitive treatments available, and there's no clear etiology known or understood that we could intervene on.
So, beyond those characteristics that you just outlined, Mike, can you tell us about the sleep-related respiratory disorders that can occur in MSA? How specific are these in establishing a diagnosis of this condition?
Well, the very term multiple system atrophy means that multiple systems are involved in the central nervous system. So in addition to the cerebellum or the basal ganglia and the autonomic part of the nervous system, the brainstem is very much involved. So not surprisingly, sleep apnea is extremely common. And you might think it's going to be central sleep apnea from brainstem involvement, but it is much more commonly obstructive sleep apnea. About 80% of patients with MSA will have sleep apnea, and the vast majority it will be obstructive, though some will have central and some combinations of the two. As the disease progresses towards its end stages, and sometimes earlier, depending which neuronal groups are involved, you can also get central neurogenic hypoventilation with rising CO2 due to, especially at night, due to degeneration of respiratory neurons in the brainstem. But of course, both obstructive and central sleep apnea are non-specific. What is the most specific respiratory disorder in MSA is stridor. Stridor, almost always starting at night during sleep, occurs in about 40% of patients with MSA. And this is a very significant finding that we should all be very aware of. How does one diagnose stridor? Well, it's really a sound, and you've got to listen. On a polysomnogram, if you look at the recording, it just looks like snoring. It's also inspiratory generally. You can't tell just looking at it. It has a slightly different frequency, but we don't measure frequencies. But it's a more strangulated, sometimes higher pitched sound. It's sort of, you recognize it when you hear it. It's sort of, oh, no, that's more of a snore. Um, That's more like it, a strangulated sound. And sometimes the family will tell you, but it's very important for them to bring recordings so you can listen. Anybody in whom you suspect stridor, with or without obstructive or central apnea, you need to do a polysomnogram, and you can very easily listen, and you have to listen. You can't just see it on the tracing. You've got to listen the next morning and say, yep, that's stridor. It's not just snoring. And it's not always easy because you can get a sort of strangulated snoring as well, but most often we can differentiate the two. Um, so that's the important one, and I think we'll talk a little later about why it is so very important not to miss that.
What do we know about the mechanism of stridor in MSA, Mike, and in particular, how that mechanism might change over the course of the disease?
Yes, there have been interesting studies in which EMGs have been done of the laryngeal muscles. Sounds a little invasive, but you can actually do EMGs of the various laryngeal muscles. And, when one breathes in, normally the vocal cords abduct. And when you breathe out, they adduct. What seems to be happening is not just early on that there's paralysis of abduction, but there is co-contraction of the abductors and the adductors, and sometimes even the adductors are stronger than the abductors. So instead of the cords moving nicely out, they move in. And that's due to what could be thought of as a dystonia of these muscles, that they are occurring at the wrong time. And this is due to disease in the control mechanisms of the larynx in the brain stem. So that's early on. But other studies suggest later in the disease a different mechanism takes place, and that's actually degeneration of the motor neurons in the branchiomotor nucleus of the vagus, which controls the abductors, and you actually have paralysis. So we always have our ENT specialists looking down at the cords. Now, that's of course during wakefulness, and that doesn't tell you what's going to happen necessarily during sleep. But during wakefulness, you can tell, are the cords abducting normally? Are they abducting but less well than they should? And then are you getting paradoxical adduction? And finally, are the cords just totally stationary, paralyzed, they don't move at all? And that can be very helpful, but of course it may be different during sleep.
Now, are stridor and or the sleep apnea types that you described prognostic factors in MSA? How should a provider be treating stridor and or sleep apnea in MSA?
Yes. Um, Studies have tended to suggest that obstructive sleep apnea itself is not a prognostic factor. You may want to treat it because make patients comfortable, less sleepy, better sleep at night, but it doesn't seem to affect the prognosis. On the other hand, multiple studies have suggested that stridor is a risk factor affecting prognosis. We studied this many years ago in our patients here and did find, in fact, that it was a prognostic factor. And there have been other studies since and meta-analyses suggesting stridor is a factor. There are multiple case reports and series of people who have died suddenly in their sleep in multiple system atrophy. And the main mechanism seems to be vocal cord dysfunction and sudden collapse of the vocal cords. So yes, it's important to be aware of it. So we study them all. We do split night studies, and in the second half of the night, we put them on CPAP, even if they don't have obstructive sleep apnea, which almost all of them have. And then we try to turn up the PAP pressure until we get rid of the stridor. If we're successful in controlling the stridor, then in most patients, the first line of treatment is CPAP at night. And that usually takes care of it, at least in the early and mid stages of the disease. Now, there are some patients in whom you may want to be potentially more aggressive, and there are really three factors. The first is you can't control the stridor even at high CPAP pressures. The second is you look down at the vocal cords and they're fixed. That's a bad sign. And the third is the patient's getting daytime stridor instead of nocturnal stridor. And generally, in those cases, we discuss with the patient the possibility of tracheostomy. Now, that's a very serious discussion and almost always a very difficult discussion. Often the stridor has started early in the disease when their motor function is still pretty good. And sometimes it's the presenting feature of the condition altogether. And they don't know about the stridor. Their partner tells them, and here you are talking to a patient who's not even aware of the stridor and saying, well, you may die in your sleep, we should do a tracheostomy. You can imagine the sort of responses we get. Tracheostomies are not easy. You've got to care for them. Later in the disease, when a patient develops motor impairment, they may not be able to do that at all, and they may have their partners to look after it. We try reassure them, you can still swallow, you plug the trach during the day and you can talk, no problem, but it is a problem. It's a difficult thing. And in addition, it's an invasion of body image. It really is. And if the stridor becomes severe later in the disease, the patient may well say, you know, I've got a progressive downhill condition. You can't stop it. I've got a lot of motor impairment. I don't need this in my life and I don't want it. If I die in my sleep, I die in my sleep. And all those are very reasonable considerations. So in practice, the majority of patients turn down tracheostomy. Though there are studies suggesting if you do tracheostomy, you do prolong life. The problem is you don't prolong it indefinitely. This is a progressive disease, and even with tracheostomy, people still die, presumably from primary neurogenic respiratory failure. You can offer them bilevel and non-invasive ventilation, but that gets a little more invasive towards the end of the disease, and most won't want that either, but certainly that can be done, especially in the rare case in which the respiratory problems predominate early on and they've still pretty good motor-wise. But it's a challenging disease to manage because of this, and one has to have a lot of compassion and understand the patient's input and thoughts about their disease and their prognosis and how they wish to do it. But I have to tell patients we can delay death with tracheostomies, but we can't entirely prevent them. The last thing to say is there have been reports of people who develop central apneas with tracheostomy, rather like treatment emergent centrals on CPAP. There's no evidence that's particularly harmful, but that can happen as well. That's probably not a cause of death as far as we know.
That's very helpful, Mike, particularly for our listeners as they may have to navigate these sorts of conversations with their own patients. Uh, you've spoken a little bit about motor symptoms during the day that one might be aware of. Can you speak a little bit about sleep-related motor symptoms that may occur in MSA?
Yes. When you do the polysomnogram, you'll find the vast majority of patients have a lot of periodic movements of sleep, perhaps more than in other disorders. Most of them, they don't arouse the patient. They're just an epiphenomenon. We don't have to worry, but you'll see that. But then patients with MSA get REM sleep behavior disorder. In fact, the best figures are at least 80% of patients with MSA will, in the course of their illness, develop REM sleep behavior disorder. So expect on the polysomnogram to see loss of REM atonia, and very often you actually record vocalization or movements in these patients. The frequency of REM sleep behavior disorder is higher than in Parkinson's disease, the Lewy body Parkinson, commoner Parkinson's disease. It's high there as well, but it doesn't get up to 80%. So there are very prominent motor disturbances, and we usually would treat that with safety of the bed environment and with melatonin. In general, we'll try avoid clonazepam in a patient with potential respiratory depression and gait instability. But, we've got to keep the patient safe. So that's the other side of sleep disorders in MSA are the motor disorders, but the REM sleep behavior disorder is totally non-specific. You'll see that in Lewy body Parkinson's as well, whereas the stridor almost never occurs in Lewy body Parkinson's. If early on you've got a patient with Parkinsonism and stridor, almost certainly they have got MSA.
Mike, are there any clinical scenarios under which tracheostomy should be considered emergently or urgently more so than other times?
Yes, that's a difficult one, and those patients usually present to us late on a Friday afternoon just through sheer chance. Of course, they don't, but that's how you sometimes think about it. If a person has incessant stridor during the day, and I've had one or two of them sitting in my office going, that's urgent. That really suggests that they may easily stop breathing during the night, and I send them straight to the emergency room to be seen by an ENT specialist that day. If they have immobile cords on laryngoscopy, that might also suggest that we need to move faster. But to be quite honest, there have been cases of people who just have stridor and no particular red flags, and within 24 to 48 hours of diagnosis have died in their sleep. Now, that's not common, but there are reports of that in the literature. So it's hard to know when it is urgent and when it isn't. I tend to study them. If they're not having it during the day, I'll study them straight away as soon as I can and have a long chat to them. But as I said, unless they are horribly distressed with daytime stridor, most of them want to think about it and don't want to move. Though I do tell them that if we're going to do this, it's probably sooner better than later. But again, if CPAP's working and it's during the night only, we'll go with CPAP first.
Now, pure autonomic failure is a related disorder. How is it related to MSA? And do we find similar sleep disorders in this condition as well?
Well, pure autonomic failure is sometimes called idiopathic orthostatic hypotension, and these are patients who present with lightheadedness and sometimes syncope standing. You check the blood pressure and it plummets down when they stand up. They may have other autonomic problems such as bladder dysfunction, that's not uncommon, and sometimes others like loss of sweating, but they usually present with orthostatic hypotension. And you examine them, they've got no cerebellar problems, they've got no Parkinsonism, it's just autonomic. So we call that pure autonomic failure or idiopathic orthostatic hypotension. And the pathology seems to be at that stage generally in the peripheral autonomic ganglia rather than predominantly in the central nervous system. The problem, you can treat it symptomatically. There are drugs available to push up the blood pressure, and there are various non-pharmacologic ways of treating it. Sleep with the head of the bed raised. Don't restrict salt input. Sometimes binders over the legs or the abdomen, that's uncomfortable. And then there are drugs that are available, but that's beyond the scope of what we're talking about today. The issue is that if you follow those patients, the vast majority will either develop Lewy body disease or MSA with time. Lewy body would be commoner. They'll develop Parkinsonism, typical Lewy body Parkinsonism, but sometimes they'll move on to MSA rather than typical Parkinsonism. Can you tell early on which one is likely to occur? Well, statistically, it's more likely to be Lewy body disease. But one little trick, if they lose their smell early on, anosmia, that would be more likely Lewy body disease because most MSA patients retain their sense of smell. It's become more difficult since COVID because, of course, a lot of people lost their smell from COVID. So it's become a little harder to use that, and it's not inevitably right. Now, there are some patients with pure autonomic failure, no Parkinsonism, no cerebellar dysfunction, who have REM sleep behavior disorder. So that means the central nervous system's involved because, of course, REM sleep behavior disorder comes from dysfunction of neurons in the pons or medulla. So they've got CNS involvement early on. Now, technically, you can't diagnose either MSA or Lewy body disease at that point, because the criteria for both of those say you've got to have Parkinsonism and for MS or for MSA, cerebellar dysfunction. But we know they're getting one of those two. And occasionally you see a patient with autonomic failure, REM sleep behavior disorder, and stridor, but no cerebellar dysfunction and no Parkinsonism. And I know that patient is in the early stages of MSA, but according to formal criteria, you can't diagnose it. So, it's nosological, that of course, but we know what that patient is evolving towards. So if you see somebody with pure autonomic failure and RBD, you know that patient is going to end up with central nervous system neurodegeneration of one of those types. But again, at present, there's nothing we can really do except lifestyle changes, exercise, cognitive function increasing, that we can do to prevent those progressions, but we know it's going to happen.
Very fascinating. Mike, as always, thank you for sharing your expertise. Do you have any final messages or thoughts to leave with our listeners today?
Well, thank you. In a person with defined diagnosed MSA that's referred to you as a sleep specialist, always think stridor, always think RBD, sleep apnea, study the patients, and be well aware of the significance and ways to manage stridor is the most important thing to remember in these patients with MSA. On the contrary, the opposite way round, if you see somebody in your lab who was sent with strange noises during the night, thought to be snoring, and you say, wow, it's stridor, always think that that patient may be developing MSA. Stridor is not specific for MSA. As I said, we don't see it in Lewy body Parkinson's, but of course it can happen from structural lesions in the larynx. And there are other rare neurologic diseases, especially some autoimmune and paraneoplastic encephalopathies with stridor, but they're even less common than MSA. But always think there's maybe an underlying neurologic problem. And if you're not a neurologist, have a neurologist assess every patient with what sounds like idiopathic stridor.
Thank you again, and thank you to our listeners for joining us today.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.